And we're back with Marc Surdyka. Marc, the consistency now of you coming on is great. I love that we just get to talk more. We get to have more episodes with the two of us. We've been doing these practical series, these practical guides, which will keep coming out. But recently, we as a team chipped away at these ACL series. And there's YouTube videos, there's blogs, and now we're going to make a podcast series on all things ACL rehab. As of the time this episode's coming out, at least the first YouTube video and blog, and likely the second will come out. But we're going to dive into all things ACL rehab and the YouTube videos. I think, like you said, Marc, there's 4 or 5 total videos that will come out for ACL as a whole. We're going to likely for this podcast series do 3 conversations and recordings, condensing some of them, but we'll place all of the YouTube video links, the blogs, etc., for people if they want to watch the full series. This conversation is just on phase 1, 0 to 8 plus weeks. Marc, can you touch on what phase 1 is and where you want to start out with this introductory ACL rehab conversation?
Yeah, so the series is split into 4 phases, so 4 separate videos. And I think in a later podcast episode, it'll probably make more sense to delve into why I ended up splitting it into 4 phases. And then there's also going to be a preoperative video. So this first video, phase 1, it's really synonymous with the early stage. And I can't remember if we were in agreement here, Chris, but yeah, I stated that this phase 1 is 0 to 8 plus weeks. And the plus really just indicates that ACL rehab is a lengthy process with variability in the timelines of some of these goals. So some of these goals you may quote unquote complete by the end of 8 weeks. And some of them you might continue working on for months on end because it's necessary for successful rehab.
Yeah, in the video and in the blog, you mentioned this idea of focusing on function, not on time. Can you elaborate on what that means?
Yeah, so progress varies between individuals based on preoperative function, the extent of the injury, and the surgery performed, right? So let's say an isolated ACL rupture versus a more complex injury that also requires a meniscal repair and a variety of other factors. So it's not always helpful to compare yourself to others if you're not progressing at the rate that you hoped or expected, assuming you're doing all the right things. And yeah, rehab is largely dictated by your function, not time. So previously, oftentimes, ACL rehab would be dictated by time-based criteria as opposed to objective-based criteria. And so time does have to pass for healing to occur, but it doesn't necessarily inform us if you're ready to perform certain exercises or activities such as running.
Yeah, we had Rula Katsufaki on kind of 2 conversations, but the most recent one was on questioning this arbitrary 9-month timeline. But she talked about the history of it used to be a 6-month return based off of time itself, a 9-month, a 12-month, conversations around a 2-year, and so many patients, if not all patients, recovering from an ACL reconstruction will ask the question to the clinician or to their PT on when can I get back to running? When can I get back to sport? And resetting that expectation of this is on your function, like you just said, Marc, and these cluster of things that will progress throughout time. And as a clinician, having some general heuristics of how long these phases occur and generally how long it may take to get back to sport is helpful. And that's why, you framed it phase 1, 0 to 8 plus weeks. We have a general idea of how long it may take, but not having hard and fast, you will be here by 4 weeks. You will be here by 6 months. That's not realistic. And it creates more unnecessary anxiety around trying to get somewhere at some arbitrary time point. And if someone doesn't reach that mark, whatever it is, they don't get to run by 3 months, or they don't get back to sport by 9 months, then that puts the individual in a mindset that they failed, or that they're not doing enough, or they're doing too much, whatever it is. So setting that early expectation on these are the things that we can control. these are the general priorities and goals. Let's look at improvements over weeks and months and not focus on these hard and fast times.
Yeah, in the video as well, I mentioned that these timelines or this timeline for each different phase, for some people, it's probably conservative. For some people, it's probably a little bit aggressive. And for many people, it's just right. And in general, I think the way that I created these different phases and timelines probably is conservative for a lot of people. And I think we'll touch on this more, like I said, in a later episode. But primarily, I did that because a lot of the times, these protocols that you'll find online are performed by high level clinicians and researchers in a research setting with a lot of resources, with a lot of time, and high level athletes, et cetera. And so just trying to be a little bit more realistic for the audience who's going to be consuming this information on YouTube. And that conversation that you had with Rula about the paper that she was the lead author on recently, I believe, if I remember correctly, the patients in that study, the time frame for return to sport varied between 5.5 to 6 months all the way up to 2 years. So there was quite a bit of variability. And in general, I think for this series, the recommendation is, hey, if you're watching this on YouTube, you can likely expect that your rehab is going to take at least 12 months, if not longer, just to be on the safe side, the slightly conservative side, while still trying to recommend to focus on function, not just time.
Phase 1, the 0 to 8+ weeks, we established 5 main goals during these first few months. I'll list them out and then we can dive into each one. So 1, minimize increases in pain and swelling, restore knee extension, restore knee flexion, improve quadriceps function, and normalize walking. Let's just go down the list. Minimize increases in pain and swelling. Why is this important and how can we achieve this?
Yeah, so I chose the word minimize, and this is a semantics thing because some people might say monitor or manage. I chose minimize to put a little bit more responsibility on the patient or person watching the video. And the reason I say that is that pain and swelling are a normal part of the early rehab process. It's going to happen. But I do think it's a responsibility to minimize unnecessary increases in pain and swelling when possible, because less pain and swelling makes the rest of rehab significantly easier. It makes regaining range of motion easier. It makes improving your quad function easier, etc. And we can talk about some of the ways to facilitate this goal and why I say minimize as opposed to just manage.
Yeah, what are some of the ways to facilitate this goal with, I know we mentioned, or you brought up in the video, crutches, minimizing time on feet. Can you elaborate on those two?
Yeah, so this is why I say minimize, right? Because not everyone is going to use their crutches appropriately for whatever reason. And I understand that there may be a reason for that, but appropriate crutch use helps to minimize unnecessary increases in pain and swelling. So for however long you need them, 2-3 weeks, a slow progression from 2 crutches to 1 crutch to no crutches. But this goes back to the focusing on the function that walking without crutches is a product of good rehab, not just time or personal preference. So it's not just ditching the crutches because you're tired of using them after 2 weeks. It's making sure that it's appropriate for you to be able to walk without them. And then minimizing time on the feet, same thing. This is a person's responsibility to say, hey, maybe it isn't the best time for me to go to Disneyland. Or if I'm going to go to Disneyland, I need to be, in some kind of wheelchair or power device because, trying to take 20,000 steps, even with crutches, is not going to lend itself to minimizing increases in pain and swelling. So it's finding that balance of, being on your feet and doing your daily tasks and whatever you need to do, but understanding that excessive time on your feet, whatever quote unquote excessive means for that individual, can hinder progress if it means increases in pain and swelling. And so I think that's very simple advice, right? Use your crutches as instructed by your medical doctor, by your physical therapist, and don't spend too much time on your feet. And by just doing those two things, once again, less pain, less swelling, it's going to make it easier to regain range of motion, improve your quad function, and it's really going to help facilitate all those things that you really want to get back to doing, the strength training, the running, playing your sport, etc. And so really making this a priority early on and understanding this process early on is just going to make everything significantly easier. And one thing that I didn't include in the video, Chris, that I think you had brought up and, suggested that maybe I mentioned, and then we could talk about why I didn't, is the sweep test. Do you want to touch on what that is and why you thought that was important?
Yeah, the sweep test is assessing or quantifying a fusion or swelling within the knee joint. There's what's called a 3+, a 2+, a 1+, trace, and a 0. And you can look up videos of individuals performing some of the sweep tests. There's also a really good, I think it's a JOSPT article giving visuals of what each one is like, but it's essentially categorizing the amount of swelling within the joint. 3+ people can visualize as a super puffy, swollen knee that almost looks like a grapefruit. People will have that immediately after surgery. 2+, 1+, trace, and 0 is just descending and decreasing amounts of swelling, and you're stroking or swiping up the medial aspect of someone's knee. Depending on the grade, there's a certain amount of swelling that either stays within the joint or that can be swept back into the joint or doesn't return at all or isn't present. And utilizing that scale can be helpful for patients and clinicians to monitor throughout the process of rehab. What is the knee's response to time on feet, to a new exercise, to introducing running, and monitoring the changes in swelling through the sweep test and tracking that over time is a more objective way than either just kind of visually staring at the knee or hearing a patient's subjective response of it feels swollen or it doesn't. It's the best, I think, option we have to get a little bit more objective data on the knee's response to its current status and the introduction or current routine over time.
Yeah, and the reason I didn't include it is, well, for all of our videos, the model is usually me, Tony, or Nicole. For this series, you were also a model, and for some previous videos, you were a model. But it's hard for consistency to, let's say, get a person who has this effusion and then goes through those different grades and have each one of those grades on film to show in a YouTube format. So just for the purposes of the YouTube series, it wasn't included.
To your point of or conversation around crutches, you mentioned this in previous conversations with total hip replacement, but I think it goes for any post-operative scenario, especially these longer rehabs, where a lot of times people think that they're winning or that they're beating the timeline of rehab if they get off of an assistive device like a crutch super quick. And they try to rush past these really helpful and necessary assistance pieces to think that they're going to expedite their recovery when a lot of times it backfires. So I think you've done a good job in previous episodes and conversations, particularly around total hip replacement, but with the same overarching conversation of there's no need to rush removing the utilization of crutches and to try to return to normal walking in a manner that's too quick, because it ends up backfiring by increasing the swelling response, leading to some of these changes in gait or limping or extra knee irritation or things that's really going to slow down this early phase of rehab, where if we can really establish and do a phenomenal job these first few weeks and months, it just makes the mid stage, the late stage, and general life much easier than trying to be overly fast with these early phase goals or getting off of crutches too soon. I don't know if there's anything you want to add there, Mark.
Yeah, just reiterating what you're saying. Getting off of your crutches at 2 weeks as opposed to 3 weeks isn't going to help you return to sport faster, especially if it means that getting it off or getting off of them sooner means increases in pain and swelling, which leads to delays in progress elsewhere.
I don't know if we want to touch on it here, but eventually when people get off of crutches, is there a heuristic or general idea of what you'd recommend clinicians discuss with patients on if you have XYZ, you're probably in a good place to wean off your crutches?
I think we could probably talk about that in terms when we get to the section of like normalizing walking, because I think a lot of what we're going to talk about helps allow someone to wean off the crutches like safely and effectively. And two other things that were brought up in this first goal is a knee brace. And if people aren't aware, not every orthopedic surgeon is going to recommend a knee brace. But the knee brace, if you have one and it's there, it's to kind of limit unwanted motion, provide protection, aid in stability. It lets other people know that you've just had an injury and surgery, and so they shouldn't be, roughhousing with you at school or wherever you may be. But the knee brace is not a replacement for the crutches. The knee brace doesn't unload the knee the same way that crutches do. So recognize that the knee brace isn't a replacement for the crutches. And then the other thing that was brought up is ice, compression, elevation. These are things that you can do as often as you want, especially as a means to get you off your feet, to minimize time on your feet.
Yeah, there is, I think, a lot of push or desire to feel like someone has to be icing at all times or providing compression or elevation, which can be helpful. And generally there's minimal to no harm. However, it's not the conversation I have with patients is if you're spending way too much time on your feet and you're getting out of the crutches too quickly and you're trying to minimize your swelling response by icing and elevating your leg, but you've just done way too much that whole day, there's no amount of icing or elevation that's going to help with that, or that's going to be the biggest priority. So it can be helpful, but it's not going to offset the sheer amount that someone may do too soon, which may be the biggest issue that should be addressed and discussed. Anything else with goal 1, minimize increase in pain and swelling, Mark? Nope. Let's go to goal 2, restoring your knee extension range of motion. Why is this important, and what are some ways we can improve this?
Yeah, so this is the one goal that kind of contradicts what I said in terms of not worrying about time, because this is a goal that you want to prioritize completing as quickly as possible, because keeping your knee flexed will be your relative position of comfort, but doing what's most comfortable is not always in your best interest. And in this scenario, always just trying to keep your knee flexed is not in your best interest after an ACL reconstruction. With that being said, nothing I'm going to recommend should ever be unbearable with regards to regaining your knee extension range of motion. And you ask, like, why is it so important? And it's just that, once again, it's having full knee extension range of motion is important for regular daily function. And compared to knee flexion range of motion, it can be harder to regain, especially the longer it takes to regain. So usually it's within the first few weeks, you're really trying to emphasize this knee extension.
And are we trying to shoot for a specific range of motion, or are we comparing it to the other side? What's the recommendation there?
Generally, I think a good heuristic is trying to achieve the same range of motion as your uninvolved side. But if the uninvolved side is not a good comparator, maybe because of a previous injury on that side, the goal would be get that knee at least completely straight, right? Like 0 degrees, full knee extension. If it is a good comparator and there is some degree of hyperextension, generally you can shoot for a few degrees of hyperextension. Although, we talked about this, I think, and we were talking about this with Nathan. Some surgeons might recommend to their patients or to the physical therapist not to achieve some degree of hyperextension based on the surgery. But in general, I'd say use the uninvolved side. You're shooting for knee straight or some degree of hyperextension if that's the case. And my two preferred ways of improving knee extension would be one with the use of a heel prop, which is exactly what it sounds like. So you're taking a pillow, pad, a rolled up towel, whatever it may be, and you're propping your heel on that object and allowing gravity to bring your knee into extension. You're trying to get comfortable in that position. And over time, if needed, you can increase the height of that heel prop. You can add a light weight just above your knee, like a cuff weight, to help facilitate more of that knee extension range of motion. And you can even do, and usually you want to be on a flat, firm surface. So if you're at the physical therapist office, you might do it on the table. If you're at home, you might do it on the floor. It's just a little bit less desirable to do it, let's say, on your couch or your bed because it isn't that flat, firm surface. And you could also do it sitting up. So let's say you're sitting in a chair. You could prop your foot on another chair or another object if it allows gravity to bring your knee into extension. So that's a heel prop. And the recommendation given in the video is to try to shoot for an hour of time total per day. And so you could split that up into 4 to 6 different sessions of 10 to 15 minute durations, right? So maybe every few hours, you're making sure that you're taking the time out of your day to prop your heel and really relax into that position for at least 10 to 15 minutes. Anything that you want to add on there for the heel prop, Chris?
Yeah, what I reiterate or clarify for individuals when I'm describing it, one, I'm doing it in the clinic. They're in that heel prop position as I'm telling them how to do it at the house. The things that I'll clarify are I want the heel prop height to be high enough so the calf is floating. So there's space between whatever object they're on, like you said, whether it's the floor at the house or we're on the PT plinth. The calf is floating, which I think provides enough elevation for gravity to pull down on the knee. So I'll tell someone, or I'll slide my hand or my knuckles underneath their calf and say, find an object that at least allows this much space underneath. And then I'll also clarify there's a difference between propping up the heel to work on knee extension and elevating the whole leg. And I'll say elevation can be helpful for minimizing or managing swelling. However, that's not the same thing as working on knee extension range of motion. And I'll be very clear with that because I think some people may see or perceive them to be the same and they think they're propping up their heel working on extension, but really they just have their whole leg propped up with pillows and they're in a super bent knee position and it's not accomplishing that. So those are the two things that I commonly hit on in the clinic. And then I'll also say, ideally, if they can handle 10 to 15 minutes to begin, that's great. But I may emphasize early on these first few days, you may be able to handle only a few minutes at a time, and that's okay, but you're going to have to chunk it out quite a bit throughout the course of the day. And cumulatively, at the end of the day, shooting for 45 to 60 plus minutes. I don't know if there is significant research saying that 60 minutes is this gold standard, but if someone's getting that much time or getting close to it, there's a really high chance that that's enough total frequency and volume and exposure to move the needle forward. And if they undershoot, it's okay, versus saying, let's shoot for 15 or 30 minutes cumulatively, someone may only get 5 minutes. So unless you are aware of research supporting it, I think 60 minutes is just a good heuristic that if people undershoot and only get 30 or 45, I'd rather be, overly optimistic and shoot for 60. And it's a nice even number. But breaking it up, like you said, Mark, especially early on, is the most realistic and attainable throughout the course of the day.
Yeah, and it's good to reiterate that it's going to be uncomfortable, but it shouldn't necessarily be unbearable. The person shouldn't be writhing in pain, in tears. But yeah, it's going to be uncomfortable. It's going to feel stiff coming out of it, but also letting them know that the more that they practice this throughout the day and on a daily basis, the less uncomfortable it's going to become, the less stiff it's going to become, and just the better the knee is going to feel once they can sit in that knee extension range of motion comfortably. The second strategy is quad sets. And quad sets is just the contraction of your quad muscles with your leg straight. Ideally, once again, you're on a flat, firm surface. And then that way you can use the floor kind of as feedback where you're contracting those quad muscles and thinking about pushing the back of your knee into the floor. Sometimes initially, people may need a small towel behind the back of the knee just for comfort because they have that gap from the floor. You could also aid in external feedback, having that small towel, but then you can remove it, right? So once again, they're really facilitating that quad contraction and pushing the back of the knee into the ground. And then there's all kinds of ways to progress this in the sense of you can do it with your heel propped up as you gain more knee extension range of motion. You can use a strap so that you're kind of pulling on your calf to get a bit of a calf and hamstring stretch. You can do it. And so when I say flat firm surface, you can do it lying flat on your back, or you could do it kind of in this long sitting position with your hands at your side or behind you. Or even right here, Chris and I are recording this podcast, I can extend one of my legs and just squeeze that quad muscle as I'm recording this. Ideally, you'd be focused on your quad, but you could do it in a seated position at, in your living room, at your dining table, at your desk, wherever you are, so that you're just squeezing those quad muscles as often as possible. And I referenced in the video the Delaware protocol, which is probably one of the most cited protocols, and Delaware is a hub of ACL experts and research. And in their protocol, they recommend almost up to 3 hours of quad sets per day. So it was something like, I had it pulled up and I think I closed it, but 5 to 10 second holds of 100 repetitions. And so, they're recommending just, let me see if I can find this, but a lot of quad sets. And that's just to highlight, and I'm not to say that you have to do 3 hours of quad sets, but it's just to highlight that this is very important and you can't really overdo the quad sets. You can do this all day, every day. And it's going to help with the quad function. It's going to help with managing that swelling.
Yeah, I think you calculated the number, and you're probably pulling it up now, but I think it was like 100,000 reps a day, which is wild. The while you're looking for it, the narrative or the phrasing I use in the clinic is like you described. There's no upper ceiling. You can do this 1,000,000+ times a day. Do this as much as you can. Again, there's no harm in doing as much as possible, and that liberty is up to the person of how often they do it. But I'm not sending a stopping point.
Yeah, so 5 to 10 sets of 100 times 5 to 10 seconds per day, right? So 10 sets of 100, you could be doing up to 1,000 repetitions for up to 10 second holds per day. So that's quite a bit. I don't know if most people are doing it comes out to be 168 minutes, which is, close to 3 hours. But yeah, it just goes to show how important these quad sets are and how you probably can't overdo them.
You think there's been someone that's actually done that?
Oh yeah, for sure. I mean, there's people who are so excited to, try to get back to their sport, and they're going to do everything they can to do it as quickly as possible. And, maybe if you're a student, whether you're in high school or college, and you're sitting for, long periods of time throughout the day, you could just sit there and squeeze those quad muscles. And one thing that you can look for that we didn't mention when you're doing quad sets eventually is what's known as a heel pop. So once again, if you're flat on a firm surface and you squeeze your quad muscles and you're trying to press the back of your knee into the floor, what you might notice is your heel, the back of your heel, pop up off of the ground, however high. And that's a pretty good indication that one, you're activating your quads pretty well, but two, that you're also doing a good job of regaining that knee extension range of motion by achieving that heel pop. And so that's another way to compare side to side is, hey, can I get a bit of a heel pop on my uninvolved side? Oh, yes, I can. Let me try to shoot for that on my involved side. Because that's something that you can do, a patient can do on their own is kind of get that visual. Whereas oftentimes as it relates to, let's say, a goniometer or some other range of motion measurement, that's being done by a physical therapist or another clinician. A patient isn't taking a goniometer and measuring their own knee extension range of motion, but that heel pop can be a nice little objective measure.
Yeah, you have this passive knee extension cumulatively throughout the day and the week, the heel prop. The quad sets, this active priority of waking up the quads and trying to achieve knee extension. Another passive option that I think a lot of people use or think is helpful is the prone hangs. What are your thoughts on prone hangs, Mark?
I thought about mentioning it, but then just as like a quick oversight, I didn't include it. I'm not a big fan of them. I think they can be uncomfortable. And then, sometimes there's just hamstring guarding. So prone hangs would mean, let's say that, because at home, you'd be lying on your couch maybe, or your bed, and the lower part of your leg is hanging off of that while you're lying on your stomach. Up to like, just above the knee, down is hanging off the bed, and you're trying to let gravity, once again, pull your leg into extension. But I think, yeah, it can be uncomfortable. And then sometimes, if the hamstrings are kind of contracting, guarding, then I don't know. I think the just heel prop on your back or in long sitting is more beneficial. What do you think?
I agree. And I don't know if it's just that's how I've always done it. And I haven't fully explored or used the prone hang often enough to have a true comparison, but I do see and can conceptualize that hamstring guarding position or tendency and just not as comfortable laying on your belly for some individuals than just a seated or laying down on your back heel prop, which I think generally is smoother. Anything, yeah.
I would say one other thing that I forgot to mention is that if you're doing this in sitting, so let's say you're sitting in your dining room chair and your foot's propped on another dining room chair and you wanted to increase that stretch, you could use something like a tote bag, right? Like let's say your Trader Joe's bag or whatever bag that's comfortable, and you put one strap kind of above the kneecap, the other strap below the kneecap, and you could put a light weight in that bag. So it's just pulling your knee further down into extension if you didn't have an ankle weight.
The other thing with tracking knee extension and making sure it's, like you said, at least getting to zero with the goal of getting to the other side if there is hyperextension, is the concern around a cyclops lesion. And I don't think we'll have time or it's necessary to dive into it in this conversation. If someone wants to hear more about what a cyclops lesion is, we had a great conversation. I'll link it with Eric Mehta about early stage rehab, but we spent a lot of time on what it is, how to track it, management options. But I think that is worth at least noting here and allowing people to go to another resource to listen more. Anything else with the knee extension before we dive into goal 3?
No, once again, this phase is labeled as 0 to 8 weeks plus, but ideally you're achieving that full knee extension far before that 8-week mark.
Goal 3, restoring your knee flexion range of motion. Why is this important compared to knee extension, and how can we achieve it?
Yeah, it's important for the same reason, in the sense that you need your knee flexion range of motion to perform your regular activities, to perform sporting movements, to perform some of the strengthening exercises that you're going to be doing in this phase or the next phase. thankfully, restoring knee flexion doesn't require the same volume of exercise, and it doesn't necessarily need to be achieved as quickly. Generally, the thought might be around the 6-week mark, you have 120 degrees of knee flexion or so. And then by the 8-week mark, maybe you're at your full knee flexion range of motion, or getting close to it. So there's a little bit more wiggle room with that timeline, while knowing that there are going to be restrictions or precautions in some cases. And the example that I gave in the video is if you had a meniscus repair, you might be limited to, let's say, 90 degrees of knee flexion initially to allow for appropriate healing before you go on to progress that. And so that's another reason why function is more important than time, is that the timelines are going to be very variable between people based on these different factors that I mentioned at the start. And so 2 ways to improve knee flexion range of motion. 1, heel slide. So this is just lying on your back. If you have, let's say, like a quote unquote slippery surface, hardwood floor, tile, whatever, if you're just wearing socks, or if you're on something that, maybe requires like a slider, it's really just actively, lying on your back, actively pulling your heel toward your butt while keeping your heel on the ground so that you're pulling your knee into knee flexion. And then a way to assist that movement is to have a belt, a strap, something that you can kind of loop around your foot and or ankle to assist pulling your knee into further knee flexion. And I think that's something that's just super easy. And you could do it, multiple times per day. Any thoughts there, or any other thoughts on knee flexion before the second one?
Yeah, the heel slides, I prescribe that as the main knee flexion option or strategy. I'll contrast it or compare it to the heel prop knee extension. I'll say with the knee extension, a lot of this is just you're passively hanging out. There's going to be a little bit more effort on your part regaining your knee flexion. Instead of duration throughout the course of the day, we're going to use sets and repetitions. And I'll typically say, let's shoot for 3 times a day. You can think of breakfast, lunch, and dinner, 2 to 3 sets of 15 to 20 reps, somewhere in that range. But I'll emphasize this is a frequency game, chipping away throughout the course of the day. And like you mentioned, Mark, with knee extension, there's going to be some level of discomfort getting into progressively greater ranges, but it shouldn't be unbearable, like you said. And as we're going through this, their first, post-op visit, I'll also reassure them like, hey, you notice that it's not super comfortable as you get into knee flexion, but that's a pretty transient symptom response. Almost immediately, people will have an alleviation or a dampening down of symptoms as they return back to knee extension. So going through the range of motion, it can maybe feel alarming for some people early on, like, oh, am I doing damage? Is this too soon? You can reassure them like, yeah, it's kind of cranky as you're getting into flexion. That goes away pretty quickly if you notice, and just reassuring them that it's okay to have some level of symptoms. You don't need to be aggressively crushing range of motion early on or flexion, but we do need to track it and make sure it's moving in the right direction. Some people, I think, are overly cautious where they don't want to move into any symptoms, and then we're concerned they're staying at 90 degrees for 4, 6, 8 weeks. And these aren't the people that have the range of motion restrictions from a meniscus repair or anything else. They just really are not getting to the range. But I would say in most contexts, people are getting progressively over time into the ranges that they need, but they also don't need to aggressively crank into knee flexion post-op, week 1.
Yeah, here's a random example I just thought of. So let's say you do a heel slide, you pull your knee into 90 degrees of knee flexion, and it makes you wince. That's the idea, isn't let me pull further to make myself wince more. As you were saying, Chris, you might stop just before the wince, where you still have some discomfort, but it's not extreme and it's not unbearable. So maybe it's, let's say, random example, 85 degrees of knee flexion. You do that for the first repetition. You go, let me try that again. You do it again. You go, oh, still a little bit of discomfort, not as much. Then the third repetition, you go, oh, I can 86 degrees or 87 degrees. And then it's just that gradual recognition that you can go a little bit further and further with the same level of discomfort that maybe you had with less range of motion on that first repetition. And then you're not going to necessarily keep all of that range of motion on the first repetition of the next set the following day, but hopefully you're making, incremental progress toward your range of motion goals. And the heel slides were the only exercise I really brought up in that regard. You could do scoots. You're going to improve your knee flexion range of motion, or at least your tolerance to it with squats. There's all kinds of other strategies. It's just heel slides are my preference, and it sounds like they're your preference as well. The other thing that I brought up is biking. And I think, and when I say biking, I mean a stationary bike. And I think this is a really good strategy to use because it is very modifiable, and it's something that you'll end up doing for, let's say, conditioning. But a lot of physical therapy clinics have a recumbent bike. So a recumbent bike is kind of where you're leaned back a little bit more. So the seat moves forward and back instead of up and down. And you can move that seat as far back as you need. So you're not going through extreme ranges of motion. And you can even do partial revolution. So you start to pedal, you go through a certain degree of knee flexion, a little bit uncomfortable, you back pedal, and you just go back and forth through those partial revolutions until you can comfortably go through a full revolution. And then as that becomes comfortable, you move the seat up, and now you're moving through more knee flexion range of motion. Then when it's appropriate, you could do the same thing on an upright bike. You move the seat higher to expose your knee to less knee flexion range of motion, doing the partial revolutions if needed, and then gradually lowering that seat so that you're going through more knee flexion range of motion. And I think that's generally a pretty comfortable thing that people can do. And you could do it for an extended period of time. You could do it as a warm up. So I think it's a nice option. What are your thoughts?
Yeah, I think it's helpful. I would say biggest recommendation is for someone not to blow through a full revolution the first time they get on the bike. It can be a jarring experience for people after any knee procedure. But in general, I tell them that this is a great way to expose the knee to repetitive cyclical flexion over the course of the day. It gets you, because we are trying to minimize time on your feet, it gets you some level of activity where you're not feeling stir crazy, while also being safe and effective for regaining range of motion and just getting you some type of physical activity in a controlled manner and progressive manner.
That's a great point. So that's a great point that you bring up. If you notice yourself or your physical therapist notice you like you're squirming and you're side bending and you're lifting your hip and you're doing all of these things to compensate for the knee flexion, like just back off whatever you're doing. And it shouldn't be this writhing experience to do this.
I'll also reassure individuals, if we're tracking, let's say someone's coming into the clinic twice a week on average, which is relatively common for outpatient orthopedic rehab. After an ACL reconstruction, we're tracking knee extension and knee flexion range of motion. I, as the clinician, don't want to place a high amount of neuroticism or overfixation on every single session. Knee extension and knee flexion has to improve. Yes, like Marc said, knee extension, we are trying to improve that as quickly as possible. And if it's not improving, we need to address that or figure out what the limitations are. But if someone on a Tuesday comes in, they're at some set degree of knee extension or knee flexion. Thursday, they come back in and they've lost a little bit or they haven't improved. I'm discussing to them, we're looking at trends over multiple days, multiple weeks. If you're primarily moving in the right direction, then we're okay. And I think a lot of people want to achieve improvement every single visit or every single day. And sometimes with knee range motion, especially for flexion, someone may be hanging out at some, let's say 100 degrees or 110 for a period of a few days, or they may stiffen up and then they get to 120. And it's this kind of nonlinear process that people may expect or assume or feel like they have to on a day-to-day or session-to-session basis improve, which I don't think is realistic or necessary.
That's another great point, Chris, because I mentioned earlier, minimizing increases in pain and swelling and putting the responsibility on the patient. But that doesn't mean shaming somebody if they did go for a longer walk or they didn't use their crutches as instructed. It's just sitting down, having a conversation, understanding their point of view, and then reinforcing that consistency with these goals over the long run is going to increase the likelihood for success.
Let's go to goal number 4, improving quadriceps function. Same questions. Why is this important? And then how do we chip away at it?
Yeah, the quadriceps function is important throughout all of rehab. It's important for returning to sport safely. And we know that the quads effectively shut down after surgery, secondary to pain, secondary to swelling, the nature of the surgery itself, any associated nerve blocks, etc. So it can be very difficult for some individuals more than others to improve and kind of regain their prior quadriceps function. And so two of the best ways to improve this are things that we've already talked about. Like if you can manage your pain and swelling, that alone is going to help with your quadriceps function. And then doing the quad sets as often as possible is also going to help with your quadriceps function, because it also is going to help with ideally that pain and swelling. And I mentioned that as you get further along in your rehab, you can also do standing quad sets. So this is what's often described as terminal knee extension. So you can stand next to a wall with like a ball behind your knee. That's kind of like a squishy ball, and push the back of your knee into that ball. Or you could do it with a band behind the knee, maybe a towel between your knee and the band, and then the other part of that band anchored to a squat rack or cable column. So you could do standing quad sets. And then, generally the progression for quad sets, if you want to call it a progression, is going from the quad set to being able to do a straight leg raise. And a straight leg raise, you're lying on your back, uninvolved knee is slightly bent, and then you're doing a quad set on your involved leg, and then, lifting that leg up off of the ground a certain height and trying to do it without lag. And lag would be a slight bend in the knee. So a lag demonstrates that you're not able to completely hold your knee straight as you lift it off the ground. So it's, usually deemed an important milestone is doing these straight leg raises, often sets of 10 to 20 without lag, because that means hopefully that you can kind of maintain your knee extension when needed, without the use of the brace and standing and in walking. And ideally, you're not going to have that leg, buckle underneath you. So that's kind of the initial thoughts on quad function. Anything that you want to bring up there, Chris?
No, I agree with all of that. I want to hear your take on how to start to train the quads outside of the kind of terminal knee extension position, either in a quad set or standing TKE. What are your thoughts on isometrics, and what are some of the best maybe ranges of motion or positions to start working on those?
Yeah, so the primary function of the quads is knee extension. Obviously, we have the rectus femoris, which contributes to hip flexion and knee extension. But if you think about a straight leg raise, if you're becoming higher level, you're becoming, your function is improving, that straight leg raise has a pretty low ceiling in terms of how much it's going to train your quads, right? It becomes more of a hip flexor exercise pretty quickly, just based on the nature of the exercise. And so if you want to improve your quad function, you have to do something that incorporates knee extension. And ideally, knee extension, at a range of motion that's going to challenge the quads a little bit more effectively, right? So at greater degrees of knee flexion range of motion. And oftentimes it's thought, well, let's just do mini squats and progress them to regular squats and goblet squats and wall sits. And those are all fine exercises. They're great exercises. They're exercises that everyone's going to do at some point in the rehab. But the problem is that we've had research for quite some time now that shows that they might not be enough for improving quad function. The paper that I always reference, because this is someone from USC, and I'm a big fan, is Susan Sigward and colleagues did a paper or published a paper in 2018 where they showed that people had intralimb and interlimb compensations during squats for up to 5 months after surgery. And we'll talk about this more in the next phase, but this just means that the body is finding a way to offload the quads of the affected knee for up to 5 months, whether that's shifting to the uninvolved side or shifting the load to more of the hip and ankle. And it's not always visible. Early on, it might be visible. You're seeing that weight shift, but it's not always visible the further along they are in their rehab. So my recommendation has been for a while to initiate isometric leg extensions pretty much as soon as the person has the range of motion and as soon as they're tolerable. And the same caveat I gave in the video, I'm not trying to convince anybody of their safety necessarily. I'm not trying to break anybody's restrictions given to them by their physical therapist or surgeon, but we've known since, at least that I'm aware of, since 1995, this is a paper by Bainan et al., is that if you do an isometric leg extension between 60 and 90 degrees of knee flexion, so 90 degrees would be you're sitting on the edge of your chair and you're just kind of, and let's say your feet are hanging off the ground, right? And your shin is basically perpendicular to the floor. You have a right angle at your knee. That's 90 degrees of knee flexion. 60 degrees would be a little bit straighter than that. But if you're doing an isometric leg extension between 60 and 90 degrees of knee flexion at up to 80% intensity in this paper, there is zero strain on the ACL. So there's no reason to not implement these isometric leg extensions as early as possible. And there's a lot of ways that you can do it. You could do it with the leg extension machine where you have the machine maxed out in weight so the person can't move it. You can use, some variation of like sitting on the edge of the plinth if you're at a PT clinic, and maybe like a gait belt and a towel for comfort. But there's a lot of options for doing this. And I think, you could do them as quickly as possible. And there's other research showing, right, that because this is zero strain on the ACL, this is less than walking. This is less than doing mini squats. This is less than all of the daily activities that you're doing. So why would we not include them?
Yeah, I agree with all that. And two, when I start utilizing them, whenever we start, first session, second session, third, whenever it is, I'll sometimes use like a physio ball around their shin, and I'll be on a stool. I'll, be kind of bear hugging the physio ball, and they're kind of pushing into me because they're not really producing that much force. And then pretty quickly after that, I'll set them up edge of the table with an ankle strap around their ankle, and using an device called a Tyndek, but essentially an isometric force gauge connected to my phone to get an idea of how much force they can produce in an isometric manner. But when I introduce it early on, I think isometrics are great, especially in this position, because I frame it to them as you're in control. If this is too much on your knee or this feels like it's too uncomfortable, you can pull back. If it's too easy, if it's a piece of cake, you can push a little bit harder. And that sense of autonomy with that exercise, I think, is really helpful for people to feel like they're in control, because they are, and to have a sense of they can, adjust the throttle of, I have a ton of anterior knee pain. I need to pull it back. I don't have to tell them, they just do it. Or this is a piece of cake, I'm going to push harder, and they can really adjust throughout the course of a set or multiple sets. And that confidence and that comfortability of isometrically pushing improves relatively quickly, and it can be scalable and tracked through a variety of ways. So I'm all for a isometric quad extension or knee extension early on.
Yeah, two other thoughts that I have here is that, one, you're being realistic with this, right? People think, they automatically assume, oh, okay, leg extension, they're going to go too heavy, too hard. It's going to flare up the knee, etc. And it's like you're doing the same thing that you would do with any other exercise. Chris mentioned ball against the wall, isometrically pushing. He's kind of there for guidance. You can do manual resistance, and you can have the person try on their other side first, right? Try the uninvolved side and go, hey, show me what 100% is for this isometric. Great. Do half of that. That's 50%. Do half of that. That's 25%. Do half of that. That's 12.5%. Okay, I want you to try 12 and this is arbitrary, 12.5% on your involved side, right? It's just getting an understanding of the movement. And you're ramping up the intensity as you start, and you're slowly, ramping it down as you end. So it's not an all out push as you start and then just a come off, maybe eventually, but you're just trying to get the person, as Chris said, like to get comfortable with the movement. And then over time, they can push harder. And initially they might be limited by their tolerance. That's fine, but you're being realistic with how you prescribe and program this. And because this phase is regarded as 0 to 8 weeks plus, I do say you can do this for the full 8 weeks or longer. I think there's enough research with isometric leg extensions that shows, hey, you can improve your strength and muscle mass with isometrics, that if this is going really well and you can see that they're improving their force output over time with something like a Tindec, you can lean into it if it's tolerable and going well. I also think that you can implement, full range of motion leg extensions at some point if that's your goal. I don't really touch on it in this video or the blog, but there is research now of implementing full range of motion leg extensions as early as 4 weeks, with no negative outcomes and actually, better improvement in function. But even then, I think people might get worried. So it feels good to say, hey, 60 to 90 degrees of isometrics, 0 strain on the ACL. Like that's something that, might improve buy-in.
This is a recent case. I eval'd this individual yesterday, 15-year-old, did not have an ACL reconstruction. He had a patellar dislocation. He had a MPFL reconstruction and another procedure, but he's 2 years out. He was referred to me from an in-house strength coach. This individual has an extremely atrophied quadricep on that surgical limb, and he's now having contralateral quad tendon pain on the left leg. The surgical leg was the right. I consult with him. We do some isometric testing. He, this is the first time doing it, so we're taking it with a grain of salt. He had medial knee symptoms on that right surgical limb, but he pushed out as hard as he feel like he could, 30 pounds isometrically on the right. On the left leg, on the uninvolved non-surgical limb, he's pushing out 200 pounds. This guy weighs 150 pounds. His thigh's about half the size. And it was a great example of someone, one, that had an incomplete rehab. They're 2 years out and they have these persistent muscle mass deficits, strength deficits, intolerance to pushing at a relatively high intensity. And now it's creating downstream effects on the non-surgical leg. And it's a objective reality of this is the difference. And not starting on loading the quadriceps after any knee procedure, but specifically an ACL reconstruction, and just assuming, like Marc said, things like mini squats and wall sits and other activities, and then eventually going into running and not tracking in an isolated manner the ability and the capacity of the quadriceps or the whole knee extensor mechanism, is doing a major disservice to your patients. And you may realize that they're in a much bigger deficit in what they can tolerate and produce than you may assume, trying to just visually look at how they look and perform. And those compensations, like Marc said, the intralimb or the interlimb are going to occur. And if we don't constrain the movement and we don't start early on, there can be some massive deficits that can last for a long time. So yeah, I just wanted to use that example.
At a discrepancy like that, 30 pounds to 200 pounds, right? You could say, well, I'm going to do a very knee dominant leg press or very knee dominant split squat, or I'm going to elevate the heels. It's like, that's all good and dandy, but you're probably going to have to do more than that, because once again, there might be compensations that you don't see. I think the other benefit of isometrics, like we're talking about it here for multiple reasons. One, it's a great way to improve tolerance, just to extending the knee and producing more force. It can be a way to improve muscle mass. It can be a way to improve strength. And some of those things come along as you can tolerate more force and your knee isn't as symptomatic. But also we know that it's not necessarily uncommon for people during ACL rehab to experience patellofemoral pain, right? If they have had a patellar bone graft, or maybe if they have a quad tendon graft and they have some kind of tendinopathy. Well, great. The isometrics at 90 to 60 degrees can be a really great strategy for someone experiencing patellofemoral pain, because maybe you're, maybe that full extension is where they're the most symptomatic. And great. It can also be used for, tendinopathic presentations. So there's just a lot of layers there and a lot of uses for isometrics, I think.
Anything else with improving quad function before we go to the final goal, Mark? Goal number 5, normalizing walking. This should be obvious as to why it's important. How can we improve it?
Yeah, so I think this is kind of what you asked earlier. And I think really, for the most part, normalizing walking is a product of everything else that we've described, except for maybe knee flexion isn't as important. But really, if you're managing your pain and swelling, you've restored your knee extension range of motion, you're getting good quadriceps function, and you did, a gradual transition from 2 crutches to 1 crutch to no crutch, like your walking is going to normalize. Now, of course, you could do some gait training and different activities as needed. In the video I mentioned, you can try to improve your tolerance to, bearing all of your weight on that one leg by doing weight shifts, by doing single leg balance, by doing single leg balance and multitasking, or head turns, or marching, or, slow backward walking to facilitate terminal knee extension and weight bearing. But really, I think if you've done all of these other things really well and you haven't tried to get off your crutches too soon, that normalization of walking is going to come. What do you think, Chris? Like, do you think anything special needs to be done? How do you approach it?
Yeah, I've shifted my thoughts over the past few years. The first few months or year of clinical practice, I thought that quote unquote gait training and spending time marching over hurdles and emphasizing heel to toe and really trying to crank into it was going to fix the gait quality. But really, it was all the other things that we just mentioned: restoring knee extension range of motion, minimizing swelling, restoring some level of knee flexion, waking up the quads, me trying to force a really solid gait when there's still so much, swelling. We haven't attacked the low hanging fruit, then it's kind of pointless. So as I've progressed in my career and just seen more cases and talked with other individuals, yes, I'll utilize some of the gait training activities, but my priority is all of the things we've mentioned previously, because people know how to walk and it's not like I have to retrain them. We need to minimize the excessive things that occur after a procedure or surgery, and allow the knee and the system to kind of self-organize over time. So I'm far less, I don't know, I don't spend that much time on it. Towards the end of the session, we'll focus on it, or we'll do a little bit. Or if someone's just coming into the clinic and they need to learn how to utilize the crutches and safely ambulate or negotiate stairs, that's kind of a different conversation. But trying to force or expedite a really great looking walk, I think comes with time and restoring all the other qualities we've discussed as the previous goals. I think that's what I would say with my thoughts there. The other thing I would say is, and I think this will come in later videos, there are some things that I'll utilize for pre-run preparation. And that's really just establishing kind of the tissue abilities to hang out in a terminal knee extension position with like a floating heel, or start to utilize more Achilles and gastroc and calf musculature. But in these early weeks, really I'm just getting them comfortable with utilizing the crutches, doing some heel to toe marching, maybe some retro walking and some other activities, but the other priorities will improve the walking the most.
And here's the thing we already talked about your body wants to offload the knee. Your body wants to compensate for this compromised joint. So if you're walking with a limp or you're doing something a little bit funky because you're trying to get off your crutches too soon and you still have pain, swelling, lack of quad function, you can guarantee that you're going to be, you're compensating quite a bit. Even if you quote unquote normalize your walking and it looks good, you could probably still assume that there are still some compensations occurring there, even with normal walking. So yeah, it just highlights doing all the other things really well.
In the video and the blog, you lay out what a typical week or what programming may look like for all the things we discussed. I'll leave it up to you. Is it worth touching on kind of comprehensively what a plan would look like, or do you want to go straight into the additional strength and conditioning recommendations?
I know we're getting kind of late here. I'll try to be really quickly because you also said, what does a rehab session look like? And let's say, we're presenting this in an online format, but if you go to a physical therapist, they're going to assess, what the wound looks like. They're going to assess your range of motion. They're probably going to do some hands-on therapy. They're going to take you through a lot of these exercises that we talked about, and then maybe reassess range of motion and some of those objective measures. Now, for a home routine, I kept it very basic, right? And if you want to do more, you can do more, but doing more isn't necessarily better if you're not doing the basics really well. And for me, the big basics were the heel prop for that accumulation of an hour per day or getting close to it, as Chris mentioned, the quad sets as often as possible. You can't overdo them. The heel slides several times throughout the day. And then, I mentioned if you have the range of motion, it's tolerable, you have the approval of your surgeon or physical therapist, doing the isometric leg extensions. And all of those things you can do every day, right? As long as it's tolerable and you're moving in the right direction. And then, as you progress along, it might be a little bit more comprehensive and maybe things you aren't doing every day, but that might involve, warming up on a recumbent or upright bike, advancing the quad sets with the strap, doing heel slides through a larger range of motion, still doing the leg extensions. Maybe you're doing straight leg raises and other hip movements, standing quad sets, single leg balance, maybe some degree of gait training, whether that's marching over hurdles or something else. And then once again, doing a heel prop, but maybe advancing that with a weight. So it can end up being a lot. And then there's still more for us to discuss, but at the very least, doing some of those basics I just outlined.
What should it look like, or what are some of the recommendations for maintaining or trying to minimize the loss of overall fitness and strength and hypertrophy and all these other qualities someone may be going into rehab with? What are some recommendations for training the non-injured leg, for the upper body, cardio, etc.?
Yeah, so same thing. We'll keep this quick, but you want to try to train your uninjured leg so it doesn't lose strength, it doesn't lose muscle mass, and it's going to be a comparator for your involved leg, right? So maybe around the 6-week mark and throughout rehab, you're going to test the strength of your involved leg, the leg that had surgery, and compare it to your uninvolved leg. And so if that uninvolved leg gets weaker, smaller, etc., it doesn't serve as good of a comparator for that leg. And now there's going to be normative values that you can compare your leg to. Also, like, there's going to be research with individuals of your age and your sport, so you can try to compare to them. But it's nice, maintaining the strength and muscle mass of that uninvolved leg as best as possible. And you're going to try to choose exercises that are safe for your involved knee. So that might be, single leg seated leg extensions, hamstring curls, calf raises, leg press, etc., as opposed to, a rear foot elevated split squat, because it's just not going to be realistic early on. So training the uninjured leg, upper body training, obviously not as much of a priority, especially for maybe some sports compared to others. But once again, it can help you feel, like an athlete, make the process more enjoyable. Once again, picking exercises that are safe. So you're not necessarily doing a heavy bent over barbell row. You're doing something that is safe for your reconstructed knee. If biking becomes tolerable, you can start trying to increase the duration of your stationary biking and stationary cycling so that it becomes long duration cardio. And one thing that I touched on here too is that because this is a long time frame, 0 to 8 weeks, you're going to be doing some degree of strength training in this process as well. Those mini squats that we talked about, step ups, step downs, wall sits, the leg extensions, the hamstring curls, maybe isometric hamstring curls, calf raises, etc. And those are all really important. They don't take precedence over the goals and the exercises that we've listed, but this is a time too within these first 2 months that at some point you're going to start doing some degree of strength training, and the next episode will really dive into the details with that. Any other thoughts for you, Chris, in terms of like additional considerations?
No, you nailed it. If people ask, I'll say these are all the things that you need to be doing. If you have the time and energy and resources and availability, here's your other options. But again, those shouldn't take precedent over restoring knee range of motion, minimizing pain and swelling, flexion, quad, etc. So it's not an immediate priority, especially within the first few weeks. But if people have all the time in the world, they have the comfortability navigating a gym, they have home resources, whatever it is, there's so many things we can do to target the non-involved leg, the upper body, the trunk, find ways to get in some consistent conditioning. But it's a back end conversation, not the priority.
Yeah, if you're doing tons of bridges and clamshells and side planks because you heard training the glutes is really important, but you're spending more time doing that than regaining your knee extension range of motion, and you're still lacking your knee extension range of motion, then you're prioritizing the wrong things. Now, once again, like Chris just said too, if you're accomplishing all those other goals and you want to spend time doing this other stuff and you want to spend a lot of time doing it, because that will help with your recovery and progressing to more advanced things, then great. Just make sure that you have your priorities in order.
You mentioned, or you discussed in the video and in the blog, dealing with doubt and uncertainty. And I'm glad you highlighted that. Can you touch on what a lot of people experience and ways to cope or think through doubt and uncertainty in an ACL rehab?
Yeah, it's a long process. They may doubt if they're ever going to return to sport. They may doubt or be uncertain if surgery was the right choice for them. They're going to doubt whether that increase in pain and swelling was just a normal part of what happened, or if they retore their ACL, they're going to be like, there's going to be so many things that they doubt and are uncertain about. There's so many exercises. There's a high volume of exercises. There's just a lot going on. And I think knowing that you're not alone, knowing that timelines vary, right? If you see a professional athlete get back in 6 months and you're still struggling at 6 months, like that's okay. Like that's normal. And it's going to be different for different individuals. So just knowing that that's a part of the process, I think can help normalize rehab. And that's true for ACL rehab or, any other surgery or injury. What do you think?
Yeah, I think some level of setting comfortability or consistency of not having all the answers or being okay with uncertainty as the clinician. If a patient asks, when will I get back to sport, or will I re-tear, or whatever it is, where there's no way to have a complete or correct or accurate answer, just acknowledging that and shifting the conversation to these are the things you can control. These are the things based on, the averages or the people I've worked with previously, giving some input and information, but not trying to always have the answer or always feel like you have to appease them by giving certainty, because that's a false sense of certainty, and that's not helpful. And letting someone sit with and be comfortable with the unknowns and just chipping away at the rehab, the day to day, the week to week, and seeing progression is the thing that they do have control over. And as a clinician, you can help set those expectations and that environment for some level of uncertainty. Anything else, Mark, with this conversation? Maybe the last question is, when does phase one end? And any other final thoughts?
Yeah, I wanted to put that in there because these phases aren't distinct. It's an overlapping continuum. So you're not in phase one day and you've accomplished all 5 of these goals, and all of a sudden the next day now you're in phase 2. Now, ideally, you will have accomplished some of these goals, right? By the end of 8 weeks, ideally you have full knee extension range of motion, you have near or full knee flexion range of motion, et cetera. But 2 of these goals, one relates to pain and swelling, and the other one relates to quad function. Keeping an eye on your pain and swelling is going to be consistent. When you're doing your strength training, when you get back to running, you still want to keep an eye on your pain and swelling. So that phase 1 goal persists throughout these other phases. And we touched on the importance of the quadriceps. So yeah, you want to improve your quad function early on, but you're going to keep hammering away at that throughout. And then we didn't spend a lot of time on it, but the strength training, you're going to start doing some level of strength training within these first 8 weeks. And that's the bigger goal and priority of phase 2. So it continues, but phase 2, what we're going to describe, isn't done in a vacuum. You still need all these other, you still need your knee flexion range of motion, your knee extension range of motion, yada, yada, yada. So it's just very important to know, once again, we're focusing on the function here, not just time. Time will play a factor, but your function is really important throughout this entire process.
Yeah, I think of it as no one session is that important, but every session is very important. So the changes occur gradually and with consistency and enough input into the system and the appropriate priorities. And there's no one session where we're transitioning black and white to a new phase, or you're cleared abruptly because of this specific day. People and the clinician and patient should be aware of these shifts and continuum of goals and priorities and the plan over time. Just like any other appropriate rehab or periodization or programming, there are these subtle shifts that occur over days and weeks and months, not these hard and fast changes or black and white things that occur. It's a spectrum, and a patient shouldn't feel this intense pressure to achieve XYZ on this specific date. It's gradually occurring, and there should be an awareness of, oh, I'm improving these things. We're slowly building and adding and introducing, as opposed to today's block 2, phase 2, whatever it is. These are all the new things we're going to add. That's inappropriate, unnecessary, and I think puts too much pressure on all parties involved. Anything else, Mark, before we wrap it up?
No, I'd love to hear feedback on this series and hear if this series is helpful and if it would be helpful for other diagnoses or body regions. And Chris, really helped with the series, as well as Tony Camella and Nicole. And I said that, any good ideas can likely be attributed to them. And I take responsibility for any of the bad ones. So yeah, give us feedback on what you liked, and what we can improve upon.
Expect phase 2 episode coming out in a few weeks. We'll call it there. Thanks, Mark.